Myomectomy is a surgical procedure to remove the uterine fibroids while preserving the uterus, often performed for the symptomatic fibroids in women desiring to maintain the fertility. Symptomatic fibroids causing the menorrhagia, heavy menstrual bleeding, pelvic pain or pressure, infertility or the recurrent miscarriage, urinary symptoms, frequency retention of the bubble symptoms due to the fibroid pressure. Rapidly growing fibroids, submucosal fibroids interfering with the endometrial implantation. Contraindications like severe medical comorbidities contraindicating the surgery. Extensive fibroid diseases where the hysterectomy is more appropriate. Active pelvic infection. Types of myomectomy. Abdominal myomectomy performed through the laparotomy of an incision suitable for the large, multiple or deeply located fibroids. Laparoscopic myomectomy, minimally invasive procedure with a smaller incision suitable for the moderate sized fibroids with fewer numbers. Hysteroscopy myomectomy performed through the vagina and cervix using the hysteroscope, suitable for the submucosal fibroids projecting into the uterine cavity. Pelvic ultrasound or MRI for the fibroid mapping. Correction of anemia with a non-iron therapy or the blood transfusion. Generous organist. Euplolia may be given the preoperatively to reduce the fibroid size and the vascularity. Vascular procedure. Midline or the lump incision meter. Uterine incision performed to enucleate the fibroids. Uterine wall repaired with the layered structures. Laparoscopic myomectomy. COT insufficient to create the hemiperitoneum. Focus inside for the camera and the instruments. Fibroids exist and removed via the morcellation. Hysterectomy myomectomy. Uterine cavity distended with the fluid. Submucosal fibroids resected with the resectoscope. Advantages of the myomectomy. Uterus preservation for the future fertility. Relief from the symptoms like heavy bleeding and the pelvic pressure. Improved reproductive outcomes, especially in the fibroid-related infertility. Complications. Intraoperative. Hemorrhage due to the uterine vascularity. Injury to the bladder bubble of the ureter. Post-operative. Infection, hematoma, venous thromboembolism, adhesion formation. Long-term uterine rupture in the future pregnancy, especially after the abdominal or the laparoscopic myomectomy. Post-operative care. Pain management with NSAID or the opioids. Early mobilization to prevent the thromboembolism. Monitoring for the signs of infection of the hemorrhage. Avoidance of the strenuous activities and the intercourse for 6 to 8 weeks. Pregnancy advice. Delay conception for at least 6 months post-surgery to allow the proper uterine healing. Myomectomy is a surgical removal of the uterine fibroids with the uterus preservation, indicated in the symptomatic fibroids causing the hemorrhagia, pelvic pain, infertility, or the recurrent miscarriage. Types include abdominal, laparoscopic, and the hysteroscopic myomectomy. Abdominal myomectomy is preferred for the large or the multiple fibroids. Hysteroscopic myomectomy is ideal for the submucosal fibroids. Preoperative general occurrence reduce the fibroid size and the vascularity. Pelvic ultrasound or the MRI is essential for the preoperative fibroid mapping. Major intraoperative risk is hemorrhage due to the highly vascular uterine tissue. Postoperative adhesion formation can cause the infertility. Uterine rupture in the future pregnancy is a long-term complication. Laparoscopic myomectomy offers a faster recovery and the shorter hospital stay. Pregnancy is advised after at least 6 months post-myomectomy for the uterine healing. Anesthesial incision is commonly used in the abdominal myomectomy. Morcellation is used in the laparoscopic myomectomy for the fibroid removal. Adhesion prevention techniques are often employed post-operatively. Hysteroscopic myomectomy involves fluid distension of the uterus for the visualization and the resection. Myomectomy improves the fertility outcome in women with the fibroid-related infertility.